Good day, good day, good day. Welcome to another edition of the Dr. Jeff Experience, probably the last one for 2025. But we're happy for all of our audience who have been with us throughout this year, um, right up until we ventured into public service realm. As you well know, I am a candidate for Georgia's 13th congressional district. So we're looking forward to being able to take this show on the road and helping you, our citizens of Georgia and District 13 and the nation, to become a better nation, to bring back civility to politics, to bring back common sense, to bring back some of God's love to politics, all of God's love, actually. But today, what I want you to do is I want you to share and like this if you're watching on YouTube, Facebook Live, um, YouTube Live, and LinkedIn Live. I want you to share it with somebody, hit them up and say, hey, man, you got to listen to this recording. Today, we want to dive into the history of Medicare. And the reason I'm doing that is you will hear me mention some of the stances that I take and some of the things that I would like to achieve for you. And one of those things is universal health care. Whether you hear the terms of universal health care and affordable health care, I think that you ought to know exactly what it is that candidates are talking about. And I believe that a well informed candidate, a well informed electorate, is able to make a better decision when they go into the voting booth. So, myself, I want to supply, whether you're voting for me or not, I just want you to be a more informed electorate, more informed voter. I want you to know what it is that people are talking about. And healthcare has been at the top of most of the campaign pundits' mouths, on the news, and everything else. So tonight we're going to deal with the history of Medicare, okay? So I'm going to bring some facts up and some stuff from the research department, and we're going to talk about this. So let's talk about Medicare and why was Medicare created. And I'm giving you pre-1965 context. Before Medicare, all Americans faced what was called a structural insurance problem. Private insurance commonly denied coverage, charged unaffordable premiums, or excluded pre existing conditions for seniors, and employer sponsored coverage typically ended at retirement. The result was widespread underinsurance and delayed care among older adults. Medicare emerged as a national social insurance solution, built as an extension of the Social Security framework rather than a welfare program. So eligibility could be broad, predictable, and not dependent on medical underwriting. The program was established as Title 18 of the Social Security Act by the Social Security Amendments of 1965 and signed into law on July 30th, 1965, with coverage beginning in 1966. So now I want to give you kind of a broad overview of what this means and the history of Medicare. So, Title 18 of the Social Security Act designated health insurance for aged and disabled is commonly known as Medicare. As part of the Social Security Amendments of 1965, the Medicare legislation established a health insurance program for aged persons to complement the retirement, survivors, and disability insurance benefits under Title II of the Social Security Act. So, when it was first implemented in 1966, Medicare covered most persons aged 65 or older. Medicare originally consisted of two parts: hospital insurance, which is known as HI, also known as Part A, and supplementary medical insurance, SMI, which in the past was known simply as Part B. Part A helps pay for inpatient hospital, home health agency, skilled nursing facility, and hospice care. A is provided free of premiums to most eligible people. Certain otherwise ineligible people may voluntarily pay a monthly premium for coverage. Now, Part B helps pay for physician, outpatient hospital, home health agency, and other services. To be covered by Part B, all eligible people must pay a monthly premium or have the premium paid on their behalf. There's a third part of Medicare, sometimes known as Part C. It is the Medicare Advantage Program, which was established as the Medicare Choice Program by the Balanced Budget Act of 1997 and subsequently renamed and modified by the Medicare Prescription Drug Improvement and Modernization Act, known as MMA, of 2003. The Medicare Advantage Program expands beneficiaries' options for participation in private sector healthcare plans. The MMA also established a fourth part of Medicare, known as Part D, to help pay for prescription drugs not otherwise covered by Part A or Part B. Part D initially provided access to prescription drug discount cards on a voluntary basis and at limited costs to all enrollees, except those entitled to Medicaid drug coverage, and for low-income beneficiaries. Transitional limited financial assistance for purchasing prescription drugs and a subsidized enrollment fee for the discount cards. This temporary plan began in mid-2004 and phased out during 2006. In 2006 and later, Part D provides a subsidized access to prescription drug insurance coverage on a voluntary basis for all beneficiaries upon payment of a premium. With premium and cost-sharing subsidies for low-income enrollees. Part D activities are handled within the SMI Trust Fund, but in an account separate from Part B. It should thus be noted that the traditional treatment of SMI and Part B as synonymous is no longer accurate, since SMI now consists of Parts B and D. The purpose of the two separate accounts within the SMI Trust Fund is to ensure that funds from one part are not used to finance the other. When Medicare began on July 1st, 1966, approximately 19 million people enrolled. In 2012, almost 51 million are enrolled in one or both of Parts A and B of the Medicare program, and over 13 million of them have chosen to participate in a Medicare Advantage plan. Now, let's go over entitlement and coverage. Part A is generally provided automatically and free of premiums to persons aged 65 or older who are eligible for Social Security or railroad retirement benefits, whether they have claimed these monthly cash benefits or not. Also, workers and their spouses with a sufficient period of Medicare-only coverage in federal, state, or local government employment are eligible beginning at age 65. The following healthcare services are covered under Part A. This is something that you need to know. Inpatient hospital care coverage, inpatient hospital care. Coverage includes cost of a semi-private room, meals, regular nursing services, operating and recovery rooms, intensive care, inpatient prescription drugs, laboratory tests, x-rays, psychiatric hospitals, inpatient rehabilitation, and long-term care, hospitalization when medically necessary, as well as all other medically necessary services and supplies provided in the hospital. An initial deductible payment is required of beneficiaries who are admitted to a hospital, plus co-payments for all hospital days following day 60 within a benefit period. Skilled nursing facility, SNF care, coverage is provided by Part A only if the care follows within 30 days, generally, a hospitalization of 3 days or more, and is certified as medically necessary. Covered services are similar to those for inpatient hospital care and include rehabilitation services and appliances. The number of SNF days provided to Medicare is limited to 100 days per benefit period, with a co-payment required for days 21 through 100. Part A does not cover nursing facility care if the patient does not require skilled nursing or skilled rehabilitation services. Home Health Agency, otherwise known as HHA, and it's important for you to know these terms, HHA, which means Home Health Agency. Home Health Agency care covered by Parts A and B. The Balanced Budget Act transferred from Part A to Part B those home health services furnished on or after January 1st, 1998, that are unassociated with a hospital or SNF stay. Part A will continue to cover the first 100 visits following a 3-day hospital stay or a SNF stay. Part B covers any visits thereafter. Home health care under Parts A and B has no co-payment and no deductible. HHA care, including care provided by home health aide, may be furnished part-time by an HHA in the residence of a homebound beneficiary if intermittent or part-time skilled nursing and or certain other therapy or rehabilitation care is necessary. Certain medical supplies and durable medical equipment may also be provided, although beneficiaries must pay a 20% coinsurance for durable medical equipment as required under Part B of Medicare. There must be a plan of treatment and periodic review by a physician. Full-time nursing care, food, blood, and drugs are not provided as HHA services. Hospice care. Coverage is provided for services to terminally ill persons with life expectancies of 6 months or less who elect to forego the standard Medicare benefits for treatment of their illness and to receive only hospice care for it. Such care includes pain relief, supportive medical and social services, physical therapy, nursing services, and symptom management. However, if a hospice patient requires treatment for a condition that is not related to the terminal illness, Medicare will pay for all covered services necessary for that condition. The Medicare beneficiary pays no deductible for the hospice program, but does pay small coinsurance amounts for drugs and inpatient respite care. An important Part A component is the benefit period, which starts when the beneficiary first enters a hospital and ends when there has been a break of at least 60 consecutive days since inpatient hospital or skilled nursing care was provided. There is no limit to the number of benefit periods covered by Part A during a beneficiary's lifetime. However, inpatient hospital care is normally limited to 90 days during a benefit period, and copayment requirements apply for days 61 through 90. If a beneficiary exhausts the 90 days of inpatient hospital care available in a benefit period, the beneficiary can elect to use days of medical coverage for a non-renewable lifetime reserve up to 60 total additional days of inpatient hospital care. Copayments are also required for such additional days. All citizens and certain legal aliens, let me repeat that. All citizens and certain legal aliens aged 65 or older and all disabled persons entitled to coverage under Part A are eligible to enroll in Part B on a voluntary basis by payment of a monthly premium. Almost all persons entitled to Part A choose to enroll in Part B. In 2011, Part B provided protection against the cost of physician and other medical services to almost 45 million people, over 37 million aged and over 7 million disabled enrollees. Part B benefits totaled $221.7 billion in 2011. People, this is very important for where I'm going as I talk to you about universal health care and how we have two different ways to achieve that, but Medicare for all is, you'll see, makes the most sense. Part B covers certain medical services and supplies, including the following: physicians and surgeons services, including some covered services furnished by chiropractors, podiatrists, dentists, and optometrists. Services provided by Medicare-approved practitioners who are not physicians, including certified registered nurse anesthetists, clinical psychologists, clinical social workers other than in a hospital or SNF, physician assistants, and nurse practitioners and clinical nurse specialists in collaboration with a physician. We're talking about Part B and the coverage. Services in an emergency room, outpatient clinic, or ambulatory surgical care, including same-day surgery. Home health care not covered under Part A. Laboratory tests, x-rays, and other diagnostic radiology services. Certain preventive care services and screening tests. Most physical and occupational therapy and speech pathology services. Comprehensive outpatient rehabilitation facility services and mental health care in a partial hospitalization psychiatric program. If a physician certifies that inpatient treatment would be required without it. Radiation therapy, renal, kidney dialysis and transplants, heart, lung, liver, pancreas, and bone marrow transplant, and as of April 2001, intestinal transplants. Also included under Plan B, Part B is approved durable medical equipment for home use, such as oxygen equipment, wheelchairs, prosthetic devices, and surgical dressings, splints, casts, and braces. Drugs and biologicals that are not usually self administered, such as hepatitis B vaccines or immunosuppressive drugs, certain self administered anti cancer drugs are covered. Certain services specific to people with diabetes and ambulance services when other methods of transportations are contraindicated. To be covered, all services must be either medically necessary or one of several prescribed preventive benefits. Part B services are generally subject to a deductible and coinsurance. We'll explain that in the next section. Certain medical services and related care are subject to special payment rules, including deductibles for blood, maximum approved amounts for Medicare approved physical, speech, or occupational therapy services performed in settings other than hospitals, and higher cost requirements, such as those for certain outpatient hospital services. The preceding description of Part B covered services should be used only as a general guide due to the wide range of services covered under Part B and the quite specific rules and regulations that apply. Medicare Part A and B, as described above, constitute the original fee for service Medicare program. Medicare C, also known as Medicare Advantage, is an alternative to traditional Medicare. Although all Medicare beneficiaries can receive their benefits through the traditional fee for service program, most beneficiaries enrolled in both Part A and B can choose to participate in a Medicare Advantage plan instead. Medicare Advantage plans are offered by private companies and organizations and are required to provide at least those services covered by Parts A and B, except hospice services. These plans may, and in certain situations must, provide benefits such as vision or hearing, or reduce cost sharing or premiums. The primary Medicare Advantage plans are, and I want you to note these different Advantage plans. Local Coordinated Care Plans, also known as LCCPs, Local Coordinated Care Plans, including Health Maintenance Organizations, which is your HMOs, and your provider-sponsored organizations, local preferred provider organizations. So three terms that you'll hear often: LCCPs, HMOs, and PPOs. The LCCPs, Local Coordinated Care Plans; HMOs, Health Maintenance Organizations; and PPOs, Preferred Provider Organizations, and other certified coordinated care plans and entities that meet the standards set forth in the law. This is under the primary Medicare Advantage plans. Generally, each plan has a network of participating providers. Enrollees may be required to use these providers, or alternatively, may be allowed to go outside the network but pay higher cost sharing fees for doing so. So these providers are in a network that have negotiated prices. Regional PPO plans, which began in 2006 and offer coverage to one of 26 defined regions. like local PPOs, regional PPOs, have networks of participating providers, and enrollees must use these providers or pay higher cost sharing fees. However, regional PPOs are required to provide beneficiary financial protection in the form of limits on out of pocket cost sharing. And there are specific provisions to encourage regional PPO plans to participate in Medicare. I hope everybody is with me so far. This is a lot, but it's important to know. I mean, my wife and I, we've had to deal with this with my mom, my aunt, and other members to explain to them and us understand what all of this means. So here's another term, PFFS. PFFS, private fee for service plans, which were not required to have networks of participating providers through 2010. In 2011, this is still the case for private fee for service plans in areas, usually counties, with fewer than 2 network-based LCCPs and or regional PPOs, and members may go to any Medicare provider willing to accept the plan's payment. However, for PFFS plans in network areas with 2 or more network-based LCCPs and or regional PPOs, provider networks are mandatory and members may be required to use these participating providers. So you see where I'm going? Let me give you this last one. Special needs plans, which are restricted to beneficiaries who are duly eligible for Medicare and Medicaid, live in long-term care institutions, or have certain severe and disabling conditions. So for individuals entitled to Part A or enrolled in Part B, except those entitled to Medicaid drug coverage, the new Part D initially provided access to prescription drug discount cards at a discount of no more than $30 annually on a voluntary basis. For low-income beneficiaries, Part D initially provided transitional financial assistance of up to $600 per year for purchasing prescription drugs, plus a subsidized enrollment fee for the discount cards. This temporary plan in mid-2004 and phased out in 2006. It began in 2004 and was phased out in 2006. Beginning in 2006, Part D provides subsidized access to prescription drug insurance coverage on a voluntary basis. Upon payment of a premium to individuals entitled to Part A or enrolled in Part B, with premium and cost-sharing subsidies for low-income enrollees. Beneficiaries may enroll in either a standalone prescription drug plan, a PDP, or an integrated Medicare Advantage plan that offers Part D coverage. Enrollment began in late 2005. In 2011, Part D provided protection against the cost of prescription drugs to almost 36 million people. Estimated Part D benefits totaled $66.7 billion in 2011. This amount includes an estimated $5 billion in benefits financed by enrollee premiums paid directly to the Part D plans. These direct premium amounts are available only on an estimated basis. Part D coverage includes most FDA-approved prescription drugs and biologicals. The specific drugs currently covered in Parts A and B remain covered there. However, plans may set up formularies for their prescription drug coverage, subject to certain statutory standards. Part D coverage can consist of either standard coverage, defined later, or an alternative design that provides the same actuarial value. For an additional premium, plans may also offer supplemental coverage exceeding the value of basic coverage. It should be noted that some healthcare services are not covered by any portion of Medicare. Non-covered services include long-term nursing care, custodial care, and certain other medical health care needs, such as dentures, dental care, eyeglasses, and hearing aids. These services are not a part of the Medicare program unless they are a part of a private health plan under the Medicare Advantage plan. So please excuse me for butchering some of those words. I know my wife, who has spent over 40 years in the healthcare system as a nurse, registered nurse. She'll kill me for this. And my dad, who was a pharmacist for many years. So let me go to the next part. Now that I've given you a lot of what Medicare Part A, B, C, and D, all that means, let's go to some more history. Medicare's original design from 1965 and 1966. At launch, Medicare focused on people 65 or older and had two core components, as we talked about. Part A, which is hospital insurance, inpatient hospital and related post-acute services, financed primarily through payroll taxes into the Hospital Insurance Trust Fund. You and me. Part B, supplementary medical insurance, SMI, physician services and outpatient care, financed through beneficiary premiums and general federal revenues. This A and B structure was deliberate. Part A reflected earned social insurance. Part B allowed shared financing and optional enrollment design through enrollment became effectively standard. Let's go with number 3, major expansions and redesigns, a timeline of turning points. So in 1972, Medicare expands beyond seniors, disability, and some other stuff we'll talk about. In 1972, Medicare's eligibility expanded to include certain individuals under 65 with long-term disabilities after a waiting period tied to Social Security disability insurance. Individuals with end-stage renal disease requiring dialysis or transplant, one of the earliest examples of disease-based eligibility in U.S. federal health coverage. Now, this is a critical historical precedent for universal coverage. Medicare proved that it could extend eligibility beyond age, using federal rules and financing to cover high-cost populations systematically. So now I'm getting into the weeds here when we're talking about how universal health care can work. In the 1980s, a modern payment reform and hospice. By the early 1980s, Medicare's original cost-based hospital payment methods were seen as inflationary. A major milestone was the adoption of the Inpatient Prospective Payment System, PPS, using diagnosed-related groups in 1983, shifting incentives toward efficiency. The hospice benefit also became a notable addition, reflecting Medicare's role in reshaping benefit standards nationwide. In the late 1980s, something called catastrophic coverage episode. Congress passed and later repealed the Medicare Catastrophic Coverage Act in the late 1980s, a key lesson in benefit design and political sustainability. Expansions that are perceived as poorly financed or not aligned with beneficiary preferences can trigger backlash. So, in the 1990s to the 2000s, private plan option grows, which is managed care to Medicare Advantage. And we talked about this. Medicare's private plan pathway expanded over time into what is now Medicare Advantage, Part C, a mechanism for beneficiaries to receive Medicare coverage benefits through private insurers under federal rules and payments. Whatever one's policy preference, the key historical point is that Medicare evolved into a platform that can administer benefits through multiple delivery models, traditional fee for service and managed care, while maintaining federal eligibility and coverage standards. Let's talk about 2003. Prescription drug coverage becomes a core Medicare benefit, Part D. You heard us talk about that earlier. The Medicare Modernization Act of 2003 created Part D, adding outpatient prescription drug coverage in acknowledgement that modern health insurance is incomplete without pharmacy benefits. Now we get to something that is talked about. In 2010, the Affordable Care Act, known as ACA, and Medicare. Now, some people will call the Affordable Care Act Obamacare. And what's crazy about that is if you talk to some people and say, so how do you like Obamacare? They'll say, I don't want anything to do with Obama. And I don't want anything to do with Obamacare. And then you'll ask them in the same breath. So, or the next sentence, you'll say, so do you like the Affordable Care Act? And they'll tell you, yeah, I'd rather go with the Affordable Care Act. It's the same thing. This is why I'm giving you history and I'm giving you facts so that you know what it is that you're voting for and what it is that you're talking about. The Affordable Care Act included numerous Medicare provisions, payment reforms, delivery system demonstrations, and benefit improvements, illustrating Medicare's ongoing role as the federal government's primary testing ground for cost and quality reforms that can later influence the broader system. So, number 4, what Medicare became: a national health financing platform. Over 6 decades, Medicare evolved from hospital plus doctor coverage for seniors into a national infrastructure with standardized eligibility rules and enrollment pathways, defined benefit categories, parts A, B, C, and D, nationwide provider payment systems and quality programs, large-scale purchasing power influencing hospital systems, physicians, pharma, and post-acute care. So, the Center for Medicare and Medicaid Services itself frames Medicare's creation in 1965 as a foundational program with enduring impact. Number 5, what Medicare's history teaches about universal health care. Here's where we're going, guys. Medicare is often discussed as a senior program, but historically it is better understood as excuse me, a scalable federal coverage architecture Key lessons for universal health care include universal-like coverage can be built in phases. Medicare expanded eligibility over time. Seniors, disability, ESRD, additional refinements, creating a precedent for staged expansion rather than all at once shift. Lesson number 2, payment reform is inseparable from coverage expansion. Medicare's 1983 PPS change is a reminder that expanding coverage without modernizing payment can intensify cost growth. Conversely, the program has repeatedly served as the launchpad for reforms that can be scaled. Lesson number 3, benefits must reflect real-world healthcare. Part D is that proof. Prescription drugs became essential to modern coverage. Medicare ultimately incorporated them, but only after major political and policy debates. Showing universal models must account for pharmacy from day one. Lesson 4, political durability depends on earned benefit legitimacy. Medicare's identity as social insurance, especially Part A, contributes to its resilience. Universal healthcare proposals that align with that earned national benefit framing often find stronger public acceptance that means tested approaches. Number 6, and this is all research that I've put together from government websites, stuff that's already in place. Below are realistic ways Medicare structure could be used to move toward universal coverage. These are not endorsements of a single bill. They are policy mechanisms that build on what Medicare already is. Pathway A, lower the Medicare eligibility age, like 60, 55 or lower. Uses existing Medicare enrollment and provider payment infrastructure. Shrinks the uninsured rate among older working age adults. Let me say that again. It shrinks the uninsured rate among older working age adults, often the highest cost segment before age 65. It can be paired with subsidies to make premiums affordable. So why Medicare history supports it? In 1972, expansion shows that Medicare eligibility is not fixed to age 65. It has been broadened before. Here's Pathway B, Medicare buy-in option for additional age groups or employers. People or employers could purchase Medicare coverage Part A or B, like, or a comprehensive plan. Part A or Part B, like, or a comprehensive plan. This can be voluntary or structured as a public option competitor to private insurance. This works well if paired with income-based premium support. What healthcare contributes: standardized benefits plus national rules, without forcing a single payer overnight. Pathway C, automatic Medicare enrollment for specific uncovered groups. These examples could include people in Medicaid coverage gaps where applicable, individuals losing employer coverage, automatic fallback enrollment, certain high-need populations. Historic precedent: Medicare's disability and ESRD coverage demonstrates that automatic eligibility pathways can be created for defined groups. Pathway D, Medicare as the core administrator for a universal system, meaning Medicare for all. In a full universal model, Medicare's role could expand from a program to the primary payer slash administrator, leveraging national enrollment systems, benefit design templates, provider payment frameworks, quality oversight. Key design decisions would still be required, which means benefit richness, cost sharing, long-term services slash supports, provider rates, integration with Medicaid, and the role of private plans. But Medicare provides the administrative backbone. What would still need to be solved? These are important constraints. Even with Medicare as the foundation, universal health care must address issues Medicare historically does not fully solve. Number one, affordability and cost sharing. Traditional Medicare has deductibles, coinsurance, and no out-of-pocket maximum unless supplemented. Universal coverage designs typically require stronger financial protection. Benefits gaps. Traditional Medicare has limited coverage for dental, vision, hearing, and long-term services. Universal models usually must design these clearly. Excuse me. Provider participation and payment adequacy. Medicare payment levels are essential to cost control, but can raise provider access concerns in certain geographies and specialties. Number four, financing and trust fund mechanics. Medicare's financing is split. You have the HI trust fund for Part A, general revenue slash premiums for Part B and Part D. Universal approaches must decide whether to consolidate financing or maintain multi-part streams. The bottom line is this, people. Historically, Medicare is best understood as America's most successful, large-scale federal coverage platform. Created in 1965, expanded in 1972, modernized through major payment reforms in 1983, and updated with new benefit structures like Part D in 2003. Because it already functions as a national insurer with standardized eligibility, benefits, and payment systems, Medicare can support universal health care in multiple ways: gradual, age-lowering, buy-in, targeted auto-enrollment, or comprehensive, a fully universal Medicare administered model. Now, the Affordable Care Act, passed by President Obama and that Congress, did a great job. It helped us get to where we needed to be. But we need to improve this because too many people are still uninsured. So we've got to decide whether we want to go for Medicare for all, and I've given you all the components to that, or a strong public option. Before I close, let me give you some pros and cons about that. So the basic idea for Medicare for all means that it is one national health plan that covers everyone. Private insurance becomes supplemental, and everyone is automatically enrolled. When it comes to that's Medicare for all. A strong public option means that keep private insurance, but add a powerful public plan anyone can choose. When it comes to coverage, everyone is automatically enrolled. No premiums, no networks, no switching plans. When it comes to a strong public option, everyone can buy the public plan. Uninsured people can be auto enrolled. The cost to families under the Medicare for All, very low or no out of pocket costs. It depends on the design and is paid through taxes instead of premiums. The cost to families on a strong public option means premiums still exist, but the public option is cheaper. Subsidies expanded so no one is left out. Employer insurance under Medicare for All. It's replaced by a national plan. Under a strong public option, it still exists. Employers can choose private or public option for employees. So those are some of the things that we have to look at, but I believe that we can get to the point where we can have universal health care for all. It's a right. The United States of America is the only place in this world where people don't have the right to coverage when they get sick. And then it's the only place in the world where people have to file bankruptcy because they can't afford to pay medical costs, prescription drugs. You have people who are choosing whether to eat, whether to get gas, pay rent, pay mortgage, or pay prescription drugs. One or the other. They're constantly juggling. Which one am I going to do? We can do better than that. So I've given you a lot of information, but I want you to know these terms when people are talking, when people are running for office, like myself, and you have some history and some knowledge of what they're talking about. It's not something we can do tomorrow, but together, if we put our heads and minds together and our hearts together, we can get this done to make sure that everyone has access to health care. That's a right. It's not a privilege, not in these United States of America. God bless you all. Thank you for listening. Again, I hope you have a joyous holiday with your family and friends. Check on those loved ones, those friends who are alone, who have gone through some tough times this year. Don't let anybody be alone or by themselves during these holiday season or at all. Check on them. Listen, continue to go out and meet needs and tune in with me as I continue to bring you information. And you're going to hang out with me in a couple places we're going to be throughout District 13. Pray for those who are fighting a good fight out here. I love you, and there's nothing you can do about it because God is love. God is love, and that means love for all. So God bless you. See you later. Peace and blessings.